Hello everyone, my name is Arati. I'm the QI coordinator of Stanford Adult Endocrinology. Let me introduce my clinic. We have about, is this not working? How do I? Yeah. So we have about 7 MDs that deal with primarily diabetes patients. We have 3 nurse practitioners, 6 RNs, 2 registered dietitians, and 1 psychologist on board. And on the inpatient side, we have 2 APPs that are also CDs. I'm going to talk about sick day management protocols for patients on automated insulin delivery systems. The current problem that we see in our clinic, that is an increasing number of patients are on automated insulin delivery systems. And these patients, when they fall sick, their pump settings need to be changed. There is no set protocol right now that exists that defines what the settings are. And messages are sent to the providers and they stay, they wait for responses. And there is some timeline between how, when they are resolved, these queries are resolved. And this accounts for all the delays in patient care. So our aim was to improve the efficiency between patient messages and provider responses. That involved shortening the turnaround time between the patient and the provider, also reducing the messaging overhead between RNs and providers as well for sick day management. The current process map looks like this. The patient sends a message or calls in. The RN picks up the message, calls back the patient, gets all the information, talks to the provider. There's a lot of back and forth as to what the optimal settings might be. And then the RN responds back to the patient with the settings. We came up with a fishbone diagram which highlights some of the issues that we see currently in the system that contribute to a delay in patient care. One of the most important things is patients, as they go on automated insulin delivery systems, these systems are becoming more sophisticated. They've evolved into very complex machines, and patients are not very comfortable trying out new settings. They're not, very tech savvy, and they don't want to experiment with things. The product itself, they miss out some of the updates that are there for the pumps. So they need to be regularly prompted. The place has only a finite number of triage nurses that can respond to patient messages. The process of getting optimal settings is very time consuming because it contains a lot of steps. It's not very standardized. So major delay is in the process itself, as well as there's a lot of MD and RN fatigue in the sense that they have to deal with their regular clinics and then they address the patient messages that are waiting at the end of the day. So we, at our clinic, we created a survey, and internally we sent it to all the MDs that deal with diabetes patients via SurveyMonkey platform. And externally, we send the same survey through T1 D Exchange. The survey contained a case study of 35-year-old female that has a history of type 1 diabetes. And she's basically, she has days of congestion, sore throat. She has 2 days of fever. She has tested positive for COVID. And she has blood sugars in the 200 to 250 range. And we match it up with all the commercially available pump systems that are preferred by diabetes providers. So the first being Tandem. And keep in mind that every pump, because of the way it operates, we tweak the options that we gave the providers. So for Tandem, we had A, switch to manual mode, increase basal rates by 20%. B was switch to subcutaneous injections for the next 2 to 3 days. C was continue auto mode, take 10 units of Lantus in addition to the pump. D was continue auto mode and change carb ratio and ISF factor to a tighter value. And E was creates a sick day profile with increasing basal rates and the carb ratio and a correction factor again to a tighter value. And F was none of the above. And you can see that about 16 providers chose creating a sick day profile. And 10 of them said continue auto mode and change the carb ratio and ISET factor to a tighter value. And about 2 of them opted for none of the above. When they choose none of the above, they want to do their own custom settings for things. The next up was Omnipod. And for Omnipod, the preferences were varied. They were spread out. About 7 of them chose manual mode and increasing basal rates. 2 of them chose continue auto mode, take 10 units of Lantus in addition to the pump. And D, most of them, like 12 MDs, chose continue auto mode, change carb ratio and ISEP factor to a tighter value. And about 4 chose none of the above because they wanted to do their own custom settings. Medtronic was very similar, and they many of them chose continue auto mode, change carb ratio and ISEP factor to a tighter ratio. And then some of them, like 3 of them, chose switch to manual mode and increase basal rates by 20%. And quite a few, like 5 of them, chose none of the above. Last was iLet. And as you can see, there was not a real consensus on what we should be doing because iLet is a self-learning pump. So even our options that we gave the MDs were a little, subject to change because we're still discovering what we can do with iLet. So A was switch to injections for the next 2 to 3 days. B was enter meals larger than usual, and C was none of the above. And you can see that there's not really a preference, although 10 of them chose none of the above. 6 of them chose enter larger meals, and about 9 of them chose switch to subcutaneous injections for 2 to 3 days. So from the study, from the survey that we did, we noticed some limitations to this. Tracking patient messaging, how do you really gauge whether you've optimized, the back and forth messages? It's a retrospective review. We also noticed that if you want to look at the speed at which we are responding, we have to look at the timestamps and really review how fast we are responding to messages, patient messages. And since a large portion of providers chose none of the above and wanted to do their custom settings, we might have a difficulty in buy-in to our standardized protocol. But in our clinic, we want to try this out. We want to have like a sample protocol. We want to test it out with 2 RNs and see whether it's a success before spreading it out to the rest of the MDs in our clinic and having it like a standardized way of procedure for us. As a future option, we really want to publish a set of advisories for each pump by consulting the experts in the field, having a discussion about the in-depth settings that can go with sick day management, and having it as a standard for the rest of the MDs across the United States. This is our draft pump protocol for different pumps. As a side, Twist has been just released. As it becomes more commercially available, we will be adding it to this protocol view. So you can see that Medtronic and Omnipod have similar advisories. Continue auto mode with a carb ratio and a correction factor that are both 30 to 50% tighter. Tandem has create a sick day profile with increased basal rates, a tighter carb ratio, a tighter correction factor, and continue control IQ mode. And iLet is continue auto mode, consider NPH or Lantus for significantly increased insulin requirements in addition to the insulin pump. Having said this, we also want a snapshot of the patient's last sick day settings. This is because we feel like if we have the previous sickness, if we record the previous sickness of the patient and record their settings, between the advisory and these settings, we can come to a faster conclusion of their pump settings. And that's the plan, actually. Thank you for listening.
Thank you. And anybody who has any questions?
Thank you. Hi, I'm Melissa from Children's National, one of diabetes educators. And my question is, now that on Tandem, you can set a temporary basal rate on top of automated mode, would you consider adding that instead?
Yes.
Okay.
But again, we want it to be a wider discussion. with all the, providers that actually play a big major role in diabetes treatment. All right.
Thank you. I think it's a great question. On Tandem, yes, you can do temporary basal rate, but it's only for basal. And frequently patients, especially getting on steroids for asthma, it would be more prandial that might be affected. So on Tandem specifically, I don't know, maybe that's my personal opinion. So usually creating sick days management is more, but yeah, that's a great option too.
Hi, my name is Brooke. I'm a diabetes educator from Helen DeVos Children's Hospital. I was just curious, as you were working through these protocols, if you were going to add in anything regarding ketone management and standardizing that among your clinic. I know we have kind of our protocol, and that's probably different than everybody else in this
That's
room,
a
but you
very
didn't
good question.
mention that, so I was just curious.
That's a very good question, and we would like to in the future, but currently we want to get these, set of protocols standardized before we move to ketone management.
Hi, my name is Haley. I'm one of the faculty at Cincinnati Children's Hospital. I feel like these protocols primarily focus on hyperglycemia and sick day, whereas hypoglycemia and like gastroenteritis is a big concern and often what gets our kids admitted. So just wondering like if you plan to have a separate protocol based on the chief complaint or kind of how you're going to deal with that type
Yes,
of illness.
we plan to have a separate protocol, but that we haven't really discussed in terms of what we can do in terms of standardization of treatment. We do have a standardized set of instruction that the MD gives to them if they go into hypoglycemic events. But since we did deal with adult patients for diabetes, we haven't really gone into pediatric care as such for these protocols, but we will be expanding.
That's definitely a great point to include for sure. Any other?
Hi, your presentation was great. My name's Laura Emmons. I work at Penn Medicine. Just had a question about your smart phrases a little bit more. So in terms of like the previous sick day profile, would you add that to like a templated smart phrase?
Yes.
Like, is that part of a telephone encounter? Are you recording that in the patient chart for further? Because I know like some of these, like it just gets so redundant
It
with the
can be
Epic.
pulled into the, because it's on the flow sheet, it can be pulled into the telephone encounter by the RN.
Okay, even if it was like a year ago or something, do you update it or?
Not for a year, we need to talk to IT regarding pulling it for encounters a year ago.
Yeah.
But for the current, from present on to, future, we will be adding it.
As long as you're just titling it in the note what it was so that they can kind of like sift back to it possibly.
So we are working with IT on the visibility of these flow sheets because currently they only are there for the present encounter, and you can view them, but I doubt if we can pull them into past encounters. We can pull them into current, you can create another documentation encounter or a telephone encounter and pull those old notes in, but not go back, I think.
Sure.
Perfect.
Thank you.